Dr. Ehdaie, you talked about a paradigm shift in treatment of prostate cancer and the use of active surveillance. When has this paradigm shift occurred, and why is it occurring?
So over the past decade, we've learned more about the natural history of prostate cancer. And we've learned that a significant proportion of men may have been treated for a disease that may never have impacted their life. So in order to maximize their quality of life and do right by them, the idea of active surveillance has emerged during this decade and is continuing to be refined and being used by medical centers and doctors across the country.
And what do the numbers show about the percentage of prostate cancer patients out there who are using traditional means of radiation or surgery versus active surveillance?
So amongst men who would be considered eligible for active surveillance, so these are men with low-risk tumors and selected tumors, we think those numbers have increased from 10% 10 years ago to now upwards of 40% in more recent data, choosing active surveillance.
Okay. Is this something that's happening is it more likely to be happening in certain areas of the country or certain types of medical facilities?
So we think that majority of changes that occur with regard to practice management may sprout or start from academic centers. We still don't have data from private centers and even single physician practices to know that for certain. But data from academic centers suggests that this rise has occurred and continues to go up as far as men accepting active surveillance.
Okay, let me ask a really big picture question. How can it be that not treating my cancer could be a good thing or a preferable option?
So when we talk about active surveillance, the most important point to really emphasize that active surveillance is not doing nothing. So in fact, the way we can actually think about active surveillance is a treatment for your prostate cancer. It's just the most minimally invasive treatment with the least side effects. As part of that treatment, it requires close monitoring. So it's, in essence, not an observation to see what would happen to your cancer in you. It's more of a delay or deferring of treatment and then initiating treatment that would be curative when the time comes.
And active surveillance in clinical practice actually means what? What will the patient on active surveillance experience while they're there?
So the initial step is to determine and select patients who would be eligible for active surveillance. That requires a series of laboratory studies, a PSA, a biopsy, perhaps some imaging studies, and then that would translate to visits that are semi-annually, including digital rectal examinations, physical examinations, PSA testing, and that is bolstered either with annual or every 2 to 3 year serial biopsies to determine if there's been changes in the prostate cancer. Some programs will also incorporate imaging to help with that, identifying patients who have disease progression.
And what's been the reaction among patients when you suggest this? And tell me, what was the reaction of patients when you started suggesting this 10 or 15 years ago, and what is the reaction of patients right now?
So one of the biggest hurdles with active surveillance initially was acceptance by patients. And I think with more media coverage, more understanding of the natural disease, and more educated and self-aware patients, we're now seeing that acceptability increase. Meaning patients are now even coming to us and asking, am I eligible for active surveillance? Which is something you would not have seen 10, 15 years ago.
Among surgical urologists, is there a consensus now, or is there still a split in the community of your peers?
So I believe there's a consensus that we can identify patients with low-risk prostate cancer. And we believe as a group that these patients should be offered active surveillance. With regard to mandatory requirements or standards that would require a patient to go on active surveillance or even surgery, those will have not occurred and probably will never occur because there's always some importance to variability. But having patients understand that active surveillance is an option for select patients is widely accepted as something that should be done in every clinic visit.
And finally, what are the risks of genetic testing when it comes to prostate cancer?
So with, I think, all genetic testing, understanding how these tests were developed and how they were validated is the critical question. And specifically in this group of patients in which we are now gathering new data and understanding how these patients will be observed and what will happen in the long term, it's very difficult to realize if we can actually extrapolate that data to our current subset of patients that we're observing on active surveillance. So the word of caution is whenever we use genetic tests, is to really try to understand, both from a physician perspective and a patient perspective, what that genetic test is actually telling us. If we can overcome that hurdle, I think genetic tests can be welcomed in clinics. But that's still a big hurdle we're trying to overcome.
Okay, thank you very much, sir.
Thanks.